I'm now going to pass it to Kathy Slem, who will moderate our next session on credibility and trustworthiness. Kathy, you have the floor.
Thank you, Dominique, and welcome, everyone. I am Kathy Slip. I'm the former Commissioner and State Health Officer, as well as the former Preparedness Director with the West Virginia Bureau of Public Health, and I'll be moderating this session. Before we jump into our panel, I want to share with our audience that we have a live illustrator who is drawing the key messages from our panel today. So it's exciting to see folks capture our content in such a creative way. I think you'll see that on one of the live panels on the stream. So as we move into this next panel, we're going to build on the discussion around trust and Preparedness Science, and really dig deeper into the concepts of credibility and trustworthiness, some of the things that we heard from our last panel discussion that gets pre-built before the event. What makes a spokesperson credible? What makes a scientific institution trustworthy? What helps information be embraced and really drive action? What does that look like from the context of different demographic groups and different types of public health emergencies? So we have, again, a really fascinating panel representing a real range of experiences. And I will invite each speaker to share their remarks for about 5 minutes, and then we'll have a question and answer period, discussion period that follows. So if you'd like more information about the panelists, you can find a link to their bios that's been posted on the event webpage. You will find that they each really bring with them incredibly rich insights and experience. So I really encourage you to engage with them after their presentations by putting questions you'd like to ask into the Q&A window that's beneath the video player. So without further ado, I'll turn it over to Dr. Reuben Warren, who's the director of the National Center for Bioethics and Research in Healthcare at Tuskegee University. Dr. Warren.
Well, good morning and good afternoon to others. Credibility and trustworthiness. I listened to this morning panel, and it was quite interesting. At the end, I was most encouraged by the speaker talking about trustworthiness. So credibility and trustworthiness is timely. And I would suggest that trust may be intuitive or instinctive, but it wanes as distrust manifests. But differently, trustworthiness is a different framework. I'd like to frame my thoughts around the context of ethics, giving you an ethical context for my few comments in my few minutes. And I start with a definition of ethics, and there are many, but the one that we use here at Tuskegee is that ethics is a set of rules, principles, values, and ideals of a particular group of people, the systematic study of morals, concepts, and theories, typically in departments of philosophy. It came from the textbook on public health ethics, theory, policy, and practice. And I point out the notion of a particular group of people. So your ethics may be different than mine. Mine may be different than yours. It doesn't matter, but we need to understand that ethics are particular, specific to a group of people. And out of that notion of ethics came a new framework maybe 40 years ago called bioethics. And bioethics is an applied ethics focusing on doctor-patient relationships and how changes in the healthcare system affect it. I think a clear example was the challenge we've gone through with the Affordable Care Act. And you heard in the earlier presentations this morning about politics. Well, in my 50 years of doing public health, political reality is as common as anything we do in public health. So bioethics is an applied ethics focusing on doctor-patient relationships and how changes in the healthcare system affect it. And last contextual definition that I want to share with you is one of public health ethics, which is a new and emerging sphere of ethics. And it really says that public health ethics places emphasis on the conceptual base, on the ethical problematic related to the interests and health of groups, the social justice of the distribution of social resources, and the positive or social rights of individuals. The study of public health ethics requires a practitioner to effectively conceptualize and operate between the tension of individual rights and collective interests. The tension is critical to doing the work that we do. And as I listened to and read the material in preparing for this session, I came up with a couple of questions rather than some absolute concrete answers. And the first and most important one for me is, how do we operationalize emergency? What is an emergency? An emergency in some communities is really common practice, common occurrence in others. So your emergency may be my norm. So we need to operationalize what we mean by emergency. And then out of that comes, what is public health? What is public health emergency? And what I'm hoping you're hearing a tension that we must address in this conversation. The tension between the person and the institution. You may have a credible and a trustworthy individual, but he or she may be in an institution that is not trustworthy. So their credibility, their trustworthiness wanes. So when you enter into an institution and you enter into it being trusted, then be thoughtful about maintaining your trustworthiness without understanding the context in which you are. And last, and most importantly, we've heard over and over again, trust the science, trust the science. And I think that's an important thing to do. But what has happened, we've had some struggles between the science and the scientists. And so I'm suggesting that we need to think about the science, but more importantly, trust the scientists and what they've come to do. And lastly, we published an article in the New England Journal of Medicine last year and talked about trustworthiness before trust, COVID-19 vaccine trials and the Black community. And I leave you with this quote from Albert Schweitzer. And it says, "The only way out of today's misery is for people to become worthy of each other's trust." Let's talk about trust, but more importantly, let's talk about trustworthiness. Thank you.
Thank you, Dr. Warren. I love that delineation between trust and trustworthiness. It is so critical, and it really does move us to the concept that we move back behind this work to our ethics, our values, understanding those relationships that of where each of us are coming from. So without further ado, let's move forward to Dr. Alonzo Plow. Dr. Plow is the Chief Science Officer and the Vice President of Research, Evaluation, and Learning at Robert Wood Johnson Foundation, and a good colleague and friend from many years past. Alonzo.
Great, thank you. Good day, good morning, afternoon, whatever time zone you are across the globe. I'm really happy to be here. So I'm going to really kind of focus a bit on the preparedness science construct, right? We've talked a lot about trusting science and the previous comment on what is public health. I really want to talk about what do we mean by preparedness science and where that's fallen short. And I'm going to do a little, I'm not a historian, I'm an epidemiologist, but I'm going to do a little bit of history on the evolution of the preparedness construct from my 25 years in public health practice. And what I think we need to do if we're not going to keep recreating the problems that we saw around COVID-19. And from 25 years in practice, Kathy, others on this call know that public health practice is where science hits the streets, right? That context is really critical for understanding how you develop prior to any disaster. And I like the previous comments. There are chronic disasters. We just went through it. There are endemic disasters like racism that don't trigger a response, but then there are pandemic and acute responses like COVID-19 where all of a sudden there's a global recognition that this is something to deal with. So something about a preparedness science that understands chronic injustice and chronic long-standing disasters that are disruptive of people's lives and life expectancies on a day-to-day basis are just as important and critical to really addressing those disparities and building the trust for those things that we decide to call an emergency because they affect populations that are beyond those that are usually marginalized. So this is an inherent problem in the kind of evidence and the construct that we've developed in preparedness science, and we have to kind of challenge this. And again, like all the other public health practitioners on this call, we have been an underfunded field. I ran large public health departments for 25 years. But more funding and bad constructs in our science are not going to get us past where we, again, replicating what we see with the response to the COVID. And then just a quick little bit of inside public health on this one. Think about how the preparedness construct came to public health, right? We didn't do much about it unless we had emergency medical services in our department. I did that. I had that in Boston and other places. But it was really around the emergence of bioterrorism and those events, that really brought funding and a focus to public health preparedness science. And this is a very narrow, we built a science on trying to figure out aerosolized anthrax attacks. If there was a low probability event, and that ever there was, that was that one, had capabilities for practice that initially did not include community engagement or recognizing the unequal impact of disasters on populations. That kind of a science that focuses narrowly on what is easier for us to do as epidemiologists on those kind of those kinds of things like stockpiling, flu modeling, all of that, and not having the kind of engagement science, the kind of working to build trust prior to a disaster. That science is going to continue to replicate the problems that we saw. And again, I think about, when I was running emergency preparedness in LA County, and that's a small county of 10 million people. When science hits the streets there, we saw the same things that we saw with COVID-19. A lack of trust, science built on flu modeling. And again, I'm not saying we shouldn't be understanding flu modeling and doing agent-based modeling and all the kinds of things that we do, but that didn't help us build the trust in LA County, where key voices on radios in our communities were actually amplifying mistrust because we had not reached out to them before. I wrote an article in 2011 about pandemics and health equity, where we talked about those issues as they affected in LA County. I hope we can talk more about what I think the corrective to that is. And that is the trust is going to happen not in the response to a disaster, but in building community resilience collaboratively prior to those events, and then recognizing the chronic outcomes of the structural factors like racism that create an ongoing dilemma in life expectancy, quality of life, and duration in those communities. So how can you trust a public health practice that kind of recognizes you in certain contexts but does not recognize you in other contexts? How do we build those tools into our science? And I think by building those tools into our science going forward, into data systems that are more granular, community-oriented, and community understood and derived, that's the kind of data modernization we need, not just more funding of the same old data systems that failed us in COVID-19. Kathy, I went on a little long, but you indulged me. Thank you.
Great. Thank you so much, Alonzo. And I love that concept of when science meets the street, and that important recognition that you bring to it in terms of that intersection between chronic and acute crises, and that we really have to be moving upstream to the everyday work that lays the groundwork here. So we're now going to look a little bit at some of the data and where messengers evolve most credibly with Jillian Steelfisher. Jillian is the Senior Research Scientist from the Department of Health Policy and Management with the Harvard T. Chan School of Public Health. So Jillian, glad to have you with us today.
Well, glad to be here, and thank you all so much for having me. It's wonderful to see you all. As was mentioned, I'm in the Department of Health Policy and Management, but my role here and what I'm going to bring to the table is that I direct the global polling program at the school. And how I spend my days is that I talk to people thousands at a time through surveys. And so I know we had a bit of this perspective in our opening panel, and I'm sort of bring that back to it because for the past 15 years, most of my work is focused on how the public perceives public health crises defined in various ways. But I'll focus a little bit on the infectious disease side and focusing not only on anthrax attacks, which I was there for, but also H1N1, Zika, Ebola, sort of a sequence and how we learn from this over time. And so I want to sort of share a couple of lessons that I've learned that we think about sort of looking at hundreds of surveys. And I want to first start with sort of what we learn from the people who trust. Okay, so we ask people, whether or not you trust institutions, and we'll focus on the trust side of the house for a second. And I'm going to show you data from a recent survey that we actually conducted in collaboration with the Association of State and Territorial Health Officials and the National Public Health Information Coalition. And in this survey, we asked people about how much they trust various institutions for health information. And of course, some of you are thinking like, aha, we now have data and this will solve the whole problem. It's new, it's innovative. But I want to say that the data I'm showing you, I'm choosing because it's actually not new. It's findings that we see over and over again. And I take a lesson from it. So let me just pull up the slide here. Hopefully this goes well. Okay, so we asked people who they trust for information. And we asked them about a sort of series of different possibilities. And we asked them, do you trust them a great deal, somewhat, not very much, or not at all? What we see is, I could have chosen this from any survey, but this is from my most recent. And we'll see that the folks that come up at the very top here are doctors and nurses. These folks are most trusted for health information in almost every survey we see. And when I put this together with other research that we see, I think it's really important as why they rise above sort of the sort of scientific institutions. And I think it's very probable that the reason they do is that they embody two key components. So certainly they follow science and scientific recommendations for the most part in their recommendations to individuals. And there's a technical competence that we see in their training and so forth. But there is what I call like the secret sauce. There is the other side of it. It is not science standing alone. It is science embodied with compassion, because doctors also care for us. They care about us. They care for our families. And that element is something that as institutions of public health, where we're raising the sign of science, we also need to raise the sign of compassion. And I think this speaks to Alonso's point and just before, which is thinking about how we as institutions demonstrate that, how we embed that in our processes, how we embed that in what we actually do and how we become trustworthy, and also how we speak to the public about that. And I also note that, this is sort of reinforced by the fact that if I looked on this list of all the institutions, right, and my list went on for a while, asked a lot of people a lot of questions, at the very end of that list are state elected officials and local elected officials, right? So now we're looking at those who don't embody a lot of trust. And to me, those folks who come in at the end, right, less than 10% of folks say they trust them a great deal for health information, is because they embody the other side, which is that people don't feel that they have either the technical expertise or the compassion. And so what we see is sort of this real challenge when we try to think about, ways as an institution that we can embody sort of the positive side of things, right? How we can leverage this part of what the equation is. And so I want to emphasize, I think that we see sort of a theme across a lot of this discussion that science doesn't stand on its own. It's not just a technical process. And I want to turn to thinking about the folks, and I'll pull this down so we can actually see each other's faces as well, thinking about, from the folks that don't trust, we ask people, well, you don't trust this institution. We ask them, why not, right? And their answer isn't, oh, because they're too sciencey, right? There's too much emphasis on science, right? That's not what they tell us. In fact, they tell us that they don't think these institutions follow the science. So it's not that people don't believe in science per se. I think sometimes people opine like the loss of the trust in science has to do with like scientific education, and that really if people just sort of understood a null hypothesis, we would all come together around a shared set of facts. And really, I think the idea that we actually spoke about sort of in the panel earlier is that people believe in the idea of science, but they believe that it is corruptible. And so we ask people why they don't trust an institution. They say, well, they're not following the science. In fact, I believe that they've been too influenced by politics or too influenced by the private sector or their own personal interests. And so we see that folks then turn to others on the internet or wherever, where they can hold up and say, oh, yes, I have the science, and I care about you, and I'm compassionate, and I'm outside the system, and therefore can't be corrupted by it. And that is the real sort of threat to thinking about sort of how we think about science. And I think, so as we think about how to build trust in science and institutions of public health and public health emergency research, I think we need to think about science in that larger context, where we think about it as not just a standalone sort of technical improvement that we can sort of somehow convince people to believe in it. It is inherently part of becoming trustworthy. It is inherently part of having an agenda that is community-centered. that is trustworthy, that is compassionate, and that as an institution, we show we care about communities in much the same way that doctors do. And that we are distanced from the politics and we are distanced from corporate interests. And we need to think about policies that actually build on that platform if we are to engage people in a conversation around trustworthiness.
Thank you, Jillian. That's such an important combination, that science and compassion. And so I thank you for bringing that into the conversation. I think there's more that we can dig into there about that relationship between medical professionals and us as individuals that will probably inform even more we can talk about over the question and answer session. So if there are questions that people have in the chat, please do put them in so we can preload those for when we finish up our last two panelists. We now are turning and excited to turn to Dr. Alan Leshner. Dr. Leshner is the Chief Executive Officer Emeritus of the American Association for the Advancement of Science. Dr. Leshner, welcome.
Thank you very much. I'm really very pleased to be with you. I have to say that the people who have spoken before, the first panel and then the first speakers in this panel, have said everything that I thought that I was going to say. That won't stop me from saying it, but I do have to say that a great deal of wisdom has been imparted. I'm going to be a little bit heretical. I don't actually think the problem facing America or the problem facing society right now is the issue of trust per se. Trust has not been a problem for science, certainly since the 1970s when we started measuring trust. And we're very imprecise. For a bunch of scientists, we're very imprecise about what are we talking about? What do we want when we say trust? So I came up with at least three things. One, does it mean believe us? That is, does it mean you think we're telling you the truth? Secondly, do you like us? Do you respect us? And then third, why aren't you doing what we tell you to do? Why aren't you so-called following the science? So on the measures of respect and trust and whatever, the data have been consistent since the early 70s when the National Science Board first started reporting them. And if you follow Pew surveys over time, basically people like scientists, second only to the military, and a whole lot more than the rest of society. Our problem and our problem in public health is that they're not doing what we say. So why not? Well, I think there are four things operating simultaneously. Some of it's misinformation, some of it's politicalization or economic inconvenience. You know, people don't do anything about climate change because it's expensive and nobody wants to pay for it. I just put solar panels on my house and it costs $20,000. Well, that's a big burden for a lot of people. But then there are things on our side that I think that we're doing poorly. One of it is we're not always performing well. That is, but the biggest problem is that I don't think we're doing a very good job with information. I think there's a real issue, first of all, in inconsistent messages, and the minute we are inconsistent, people who don't want to do what we suggest or have some kind of interest in not doing it, they'll grab that inconsistency and say, you don't really know it. You know, 97% of the people in science believe that the climate is warming. People grab that 3%. What if the 3% is right? And then, of course, we have a tendency as scientists to circle the wagons and shoot inward around nuances. That is, to make ourselves sound as if we're not quite sure what we're talking about. Scientists like the nuances in their data. The public hear, you know, simple clauses, simple words, simple phrases, news things that get caught. So if we say, yes, we believe boom, and you should do boom, but maybe maybe not, maybe there's this little bit of doubt in it. We have to be consistent, and I think we have to be clear. People like Dominique Broussard have studied what works in effective communication about science forever. I had the pleasure of chairing a National Academy study on it a few years ago, and there are plenty of things that we've learned, including related to the things I just said. A big thing is that controversy fuels not doing what we believe is in the best interest. And again, I said what causes some of that. But also a principle that I would mention is only scientists are stuck with what we say. That is, that if I violate the scientific evidence or the preponderance of scientific evidence, I'm done. I'll have no credibility. However, as we've learned, other people can say whatever they want with relatively little misinformation. So I would say there are two things that we need to focus on, that we need to do. One is we need to try to get our colleagues to be more effective in their communication with the public. And there are plenty of reports and plenty of efforts about what works and doesn't work in engaging with the public around scientific issues. And secondly, we do have to do a more focused and more effective attack on the misinformation that is in fact working against the goals that we all share, that works against. They're the biggest problems. How to do that is not clear. There's a limited number of times you can stand up and say that person's lying before you begin to lose credibility as well. So I'll leave you with those few comments.
Thank you, Alan. And, I think it is helpful to break it down really into how we both perform and communicate. But I think what we're really getting at underneath some of this, we can go back to this in our discussion time period, is humility. How do we really, how are we have humility in how we approach this as a society? Because it is a complex intersection between the science and the practice with this. So our last panelist today is Amber Anderson. She is the research epidemiologist with the University of Oklahoma Health Sciences Center. And from prior discussions with Amber, I know she's got lots of rich concepts and ideas to share with us today as well, especially speaking of humility and understanding the context and the populations that we're working with. Amber, Dr. Anderson.
Good morning, thank you. And thank you to the Planning Committee for inviting me to engage in today's discussion. My name is Amber Anderson. Like Kathy said, I work at the University of Oklahoma Hudson College of Public Health, and I'm a citizen of the Cherokee Nation. And as a result of that, my research primarily addresses health disparities and inequities faced by American Indian and Alaska Native populations. I'd like to start today by providing a bit of a historical context to some of the distrust among Indigenous populations here in the United States, and then delve a little bit deeper into some of the complexities of building trust within Indigenous populations. So I'm sure all of you are aware of some of the federal policies that the federal government have employed on Indigenous populations and how that has failed the safety and well-being of Indigenous people. There's been gross efforts to eradicate Indigenous communities, and subsequently Indigenous culture was a critical component of colonial efforts and government policies. However, despite these efforts, tribal populations have asserted their sovereignty to protect the health and well-being of their people, and in the context of emergency preparedness, many tribes have the authority to engage in preparedness and response activity using the methods that they feel most appropriate for their constituents and their communities. Indigenous communities and people are not homogenous. I think this is a really important component when we're thinking about trust, because if the communities are not homogenous, therefore trust is not homogenous, and it's incredibly difficult to assess and measure, and therefore not well understood. But one way that tribes have exercised their inherent sovereignty is by developing their own tribal codes, emergency management and response plans, and implementing these plans in conjunction with local agencies. However, this does come with challenge, and I think overall, working collaboratively, at least here in the state of Oklahoma, has proven to be fruitful for all parties involved in those efforts. I think there's a common misconception when thinking about tribal nations and the importance of including Indigenous peoples in conversations when building trust or implementing programs. Oftentimes, I think if a service or a program is not specifically catered toward a specific demographic, we sort of let those perspectives fall to the wayside. And the truth of the matter is that Indigenous peoples are touched in some way by all programs and initiatives, and therefore it's critical to engage these perspectives in the development of interventions and implementing those interventions. So building trust is an ongoing process with tribal nations. It requires a lot more than just having a seat at the table, but that continual engagement with organizations is really the best way to build and sustain trust. Given the historical context of these relationships, trust is often not easily earned, but very easily broken. And so this is why concepts of reciprocity, continual engagement, equitable contribution are all critical to sustaining relationships with tribal nations. And I would challenge all of you to consider not only the demographics that you're serving in your programs and interventions, but familiarizing yourselves with the tribal nations whose land and resources are shared within your jurisdictions. One example of this is here in my home state of Tulsa, Oklahoma. It's on the present-day land of Cherokee Nation, Muskogee Creek Nation, and a portion of Osage Nation. And all these tribes have established agreements for mutual assistance with local police departments. And these agreements are relied upon on a daily basis, but we don't hear as much with emerging situations such as COVID and those types of things when it comes to partnerships with tribal nations. Another important consideration is who the messenger is. I think it's been well established that this is a critical part of building trust, and every tribe and nation has unique culture and different perceptions of health. And so some tribal citizens are more receptive to health information from their own tribal community in these organizations. And so an example of this is through the Association of American Indian Physicians. They had a COVID response campaign where they had videos of Indigenous providers from all across the country. These are broadcasted across the country, telling Indigenous folks to get vaccinated. They developed a culturally grounded website using the language and the words of community leaders and elders to educate the community members and also provide resources to other tribes and agencies, which is a very effective campaign. Navajo Nation also had a very effective COVID campaign. And so I'd like to close with just one last thought. This is a concept developed by an Indigenous elder by the name of Albert Marshall. It's called two-eyed seeing, and I'm sure some of you have heard of this before, but it comes from the concept of acknowledging the strengths of both the Western perspective and the Indigenous perspective, and using both of those lenses in our approaches to serving our communities and our public health. So I challenge all of you to maybe lean a little bit more on that Indigenous lens and partner with your communities. Thank you.
Thank you, Amber, for wonderful comments, really, that kind of remind us that both history matters, relationship matters, and that we really have to recognize and work with the values and the sacredness of our relationships, trusting those over time. I love the two lens aspect of that as well. So that is wonderful. And it really brings us back to some of the first comments that we heard from Dr. Warren earlier as well. So kind of come full circle with that discussion, which is wonderful. So I'm going to open up a question to the panelists here and begin to have some discussion among yourselves. I think through all of our conversations here, we have heard and understand that trust is not just about communications, but it's about how we do our work long before the event occurs and about who we are. And so I guess I'd open to the group, what are the operational principles and values that are most important to ground our everyday work in as we do this work? And then how can we best operationalize those in the midst of disaster when expediency matters? So what's that pre-work that's so important to do? And that pre-sense of who we are and grounding ourselves in our own work and our own values with community, and how do we then operationalize that in disaster effectively?
I will start with a comment. I think critically important is building relationships, because what you're talking about is having an interface with individuals. So when something comes, some disaster comes, the focus is not on the disaster, it's on the individual. So I can't emphasize enough how you build relationships, and the whole notion of parachuting in, helicoptering in and out has tremendous impact, particularly in communities of color. So relationships, ethical relationships, are critical to this issue.
I would just add to that, it's so important. Those of us in emergency preparedness, I mean, those of you, we always say the adage, if you're exchanging business cards in the disaster response center, you're probably behind in the battle already, right? But we haven't applied that to our community partners, right? If you're saying, hey, trust me, I'm going to set up a vaccine distribution center tomorrow. I mean, no, that's not going to work. And so but back to the resource question, public health departments have to be resourced and trained and build capacity to do that pre-disaster work, and that has just not been a priority. The tools to do this and the knowledge building to do that hasn't been a priority in the construct of public health science as it exists now. So, we need to apply that old emergency response adage to our community engagement practice.
I would reiterate in a way what they said, that is that scientists need to be more and more a part of their own communities so that they're not strangers coming in, helicoptering in. I like that expression. It used to be that it was heretical to engage with the public, to communicate with the public. You were supposed to stay focused at the bench. But more and more young scientists now want to be a part of the community, and I think that we should take advantage of that desire, train them how to effectively engage with the public, and then encourage them to keep doing it.
I guess I would echo one other piece of this, which is that I think it's not just about sort of training the existing scientists to go in more effectively. I think it's also about bringing the community into the public health agency. It's about hiring. It's about bringing those perspectives, making them heard. The best way to know the community is to be part of the community. And that means really embracing that. And that does require resources. That does require, like right now, a lot of public health departments, they have like someone who comes in every Tuesday when the moon is full to sort of, have outreach with the community. And it just doesn't work that way. You need people from the community who are part of the public health enterprise, who have a voice at the table on a daily basis, who have relationships inside. And that helps to understand some of the nuances. Like, I just don't think we can train people enough to sort of go out. It must actually be a true partnership where people from the community are inside. And that dialogue is one that doesn't just sort of, come at that sort of moment of like, let's make sure we know the community. Like, the community is part of it. And so I think we really need to emphasize that.
Amber, any thoughts on that one?
I don't think so. I think everyone gave sound advice.
Yeah, Kathy, I would just on that one. I mean, I didn't just want to criticize. I mean, there's some practical things we could do, and what we did in LA County when we confronted the challenge, and you can find it on the website, Los Angeles County Community Disaster Resilience Project. I mean, we went out and figured and found out people didn't know what public health was, didn't know who came together in emergency response, and what was so effective in building up that project and learning how to do this was building it on public health nurses who were already had their day-to-day work in these different regions in LA County, knew the nuances of what is different about being based in South LA versus up in the high desert, and brought community groups together in a sustained way to help us understand how to, what the path to trust building looks like, and then to build that into the practice side. And anyone who's interested can look that up and see some of the evaluations and we actually did some randomized trials to show more and less effective ways of trying to build this over time. But again, that took tremendous resources to even do that project, right? Those are the kinds of things that need to be built into this new wave of public health funding. So we just don't modernize old data systems, but we actually transform the way we do our practice.
Yeah, I do think, and from my own experience, it is both about having the capacity in the public health system, but even more broadly about changing the minds of how we do our work. So often we think of kind of the role of government as helping take care of the public, or vice versa, and there's this us and them. And reality is, it is much more complex than that, and we are partners in that work. And so it really is not necessarily we have the answers, you have the problem. It is about we have a collective issue that we need to address together, and we all have assets and strengths we're going to bring to the table as equals. And how do we really put people at the table, not just for input, but to co-solve issues and to use our strengths collectively, with that humility and that connectedness, to bring our expertises, to share. Really, Jillian, I thought back to your data around why medical professionals are so trusted, and beyond the fact that there's that mix of science and compassion, I wonder if it's also that there is a clear relationship that we know about each other as individuals in that setting. They know my inner secrets, they know my issues, they know the context, and we have a shared vulnerability. And I think when we have that shared vulnerability and those relationships, we are able to trust each other and build and know that we have our mutual benefit at heart for each other, and are able to create more creative solutions. Just a thought with some of that.
I like what you're saying. I think there is, the question asks, we've seen like your doctor and doctors, right? And your doctor does rise up a little bit more than doctors in general, but I'm still surprised at doctors as a group. And so I think people may be thinking, as you point out, how do you demonstrate this compassion? How do you have a relationship? And I think making that parallel that you're making all the way back to the organization, it's harder to do that as an organization than as an individual. That's just a task on us. We've just got to work harder. Okay. And we need resources to be able to do that. And I think maybe what I take away from what you're adding to this is really that, as we think about how to create that relationship, I still come back to like bringing the community in. That is where the relationship comes from. That really efforts need to be community led. And so it's about having the expertise of the community about its own needs and about its own solutions brought to the table in a meaningful way as kind of part of the leadership of public health organizations. And there's also some operational things that we need to think about, right? There's details like the way we fund those things. It's not just about funding it at all, but it's the operational tasks like, having funding clauses that end right at the end of at the end of an emergency. Like there's nothing for sustaining it over time. Having things that are reimbursement based as opposed to, actually being able to give money up front. These small organizations, they need support in these ways. And so I think there's like a tactical side of this that can make real the kind of relationship you're talking about, Kathy. Yeah. So that's on our agenda as well.
Well, I think that is capturing the gist of this and a wonderful way to wrap up this session. So I want to thank the panelists for their remarks and for even more so for their insights and the heart they bring to this work. So we are now going to dig even a little deeper into the issue of confidence and trust in FEPR science across diverse demographic groups.